Okay, the title of this presentation is Lesbian, Gay, Bisexual, and Transgender People with Serious Mental Illness. You may have heard the term LGBT, and it stands for lesbian, gay, bisexual, and transgender. Another term you may have heard is sexual and gender minorities, which is also used. And I'll also talk about what serious mental illness means as a term. But first I'm going to start with some case vignettes. How do I go to the next slide? Oh, that's not working either.
Let's try page up. That would be this little arrow guy here, maybe?
Yeah, I tried.
All right, let's try page up.
Are you in the slideshow?
Hmm.
You have to be in the slideshow.
Try that.
Hmm.
Oh, there we go.
Now maybe the page up will work. Just pretend we didn't have any of that interference. I'll cut it out.
Okay. So this is Martha. She's a 70-year-old woman living in a trailer in a rural area and supporting herself with Social Security and her teacher's pension. She never had mental health problems until 5 years ago when her female partner of 30 years passed away. Martha and her partner had no connections to the lesbian community, had never been open about their relationship at work or with family, and had no close friends who knew them as a couple. In the 5 years since her partner's death, Martha has had a paralyzing depression and continues to find daily activities a struggle. She gets therapy and medications from the local community mental health center, where she is open about her sexuality to her individual therapist and psychiatrist, but not to her women's therapy group. She is also not out to her primary care clinician. Martha has been diagnosed with major depressive disorder and complicated bereavement. Well, I want to go back and do that because I don't think I need to. Want me to do the whole thing?
Yeah.
Martha is a 70-year-old. So our first case vignette is Martha. She's a 70-year-old woman living in a trailer in a rural area and supporting herself with Social Security and her teacher's pension. She never had mental health problems until 5 years ago, when her female partner of 30 years passed away. Martha and her partner had no connections to the lesbian community, had never been open about their relationship at work or with family, and had no close friends who knew them as a couple. In the 5 years since her partner's death, Martha has had a paralyzing depression and continues to find daily activities a struggle. She gets therapy and medications from the local community mental health center, where she's open about her sexuality to her individual therapist and psychiatrist, but not to the women's therapy group she attends. She is also not out to her primary care physician. This is Abby. Abby's a 43-year-old lesbian, survivor of childhood sexual abuse and the foster care system. She has had contact with the mental health system since she was a child, and for many years went in and out of psychiatric hospitals due to cutting herself, alcohol intoxication, and suicide attempts. She's been in recovery from her alcohol use for 4 years and is attending therapy and psychiatry visits just once a month at the local university hospital clinic, as well as AA once a week. Abby lives with her partner, who's also in recovery from alcoholism, and both women support themselves with Supplemental Security Income, SSI. Abby is volunteering as a peer advocate in the University Hospital Psychiatric ER and is considering transitioning to part-time paid work as a step towards getting off of SSI. Larry's a 34-year-old man with a bipolar diagnosis and a reading learning disability. His reading problems and his disruptive behavior made school difficult for him as a child. By his late teens, he had been hospitalized for the first of many manic episodes. He's doing much better now, and in his first apparently serious relationship with Johnny, who's 10 years older than Larry. Johnny accompanies Larry to his appointments at the mental health center. When Larry's therapist and psychiatrist attempt to discuss his relationship with a man or connect him to resources at the local gay and lesbian community center, Larry giggles nervously and dismisses the relationship as all about sex, or he's just giving me a place to stay. This is Roger. He's a 25-year-old man who has struggled with intense mood swings, hallucinations, and paranoia since his teens. At about the same time, he began using crack cocaine, and it's not clear whether his psychotic symptoms followed or preceded his drug use. What is clear now is that Roger often hallucinates when not using crack. He mostly has male sexual partners, but also has girlfriends and considers himself queer. He attends a mental illness and chemical abuse, MICA day program run by the state hospital, but frequently misses appointments. He also uses local ERs when his symptoms are bothering him. Roger has not followed through with disability or Social Security applications and mostly lives off the support of friends and family. So let's talk about serious mental illness. Other terms that you may have heard are severe mental illness, severe and persistent mental illness, chronic mental illness. Serious mental illness is the most current term being used. And as you may well know, it doesn't refer to any specific diagnosis, but it refers to level of functioning in terms of work, relationships, ability to stay out of the hospital, take care of yourself. And as you might have gathered from the different vignettes, there were a variety of diagnoses, with Martha having major depressive disorder, bereavement, Abby being diagnosed with post-traumatic stress disorder, bipolar disorder, borderline personality, alcohol dependence in remission, Larry having bipolar disorder, and Roger having schizoaffective disorder, and cocaine dependence. It's estimated that about 6% of the population have serious mental illness. This is from epidemiologic studies. And although, as I've said, it's a diagnostically heterogeneous group, it doesn't refer to one specific diagnosis, but of course the more severe diagnoses are more highly represented in this group, so there are more people with depression who would fall into the category of serious mental illness. Did I just say there are more people with depression or more people with schizophrenia?
I'm not sure.
Let me say it over again.
Okay.
So as I said, this is a group of people who are diagnostically heterogeneous. Serious mental illness doesn't refer to one diagnosis, but because of it meaning a more severe presentation, the more serious diagnoses such as schizophrenia are more highly represented in this group. There are common issues in people with serious mental illness. Many people are supported by programs like SSI, SSD, and many of these folks receive services through the public mental health system. So for a long time it was difficult to comment on how many people with LGBT. Okay, for a long time it was difficult to comment on rates of mental illness in people who are lesbian, gay, or bisexual because these studies were only done with convenient samples. They were not done with representative population samples. More recent studies have used large representative sample survey data, but unfortunately most of the studies only get one question about sexual orientation, so it can be a behavior question. Do you have male partners, female partners, or both? Or it could be an identity question. Do you identify as gay, straight, bisexual, lesbian, other? So since sexual orientation is a little bit can be complicated, people can answer those questions differently. You have to keep that in mind when looking at the studies. So this first group of study is men and women who report same-sex partners. So this was a behavioral question. And in those studies, these men and women report increased rates of depression, anxiety disorders, post-traumatic stress, substance use disorders, and suicidal thoughts and behavior compared to people reporting heterosexual partners. And these are the references below. And here are the studies talking about self-identification. Self-identified lesbians and bisexual women had higher rates of generalized anxiety disorder than heterosexual women, and self-identified gay and bisexual men had higher prevalence of depression and panic disorder. So you may be wondering why in the previous slides I didn't talk about transgender people. That's because none of those studies included transgender people. There's less data in general on transgender people, and it's not at the epidemiologic or representative sample level. It's still at the level of convenience sampling, where you go to a location and solicit people, you go to a LGBT center, or you go to an event, or you go to a clinic and sample a group that may not represent the whole population. But nonetheless, in looking at, and also there's another caveat for this. Let me go back and just do this one over again. So you may have noticed that in the previous slides I didn't talk about transgender people, and that's because none of those studies asked about transgender people or identified them. In general, there's less information on transgender people, and it's still at the level of convenience sampling, where you go to an event, or you go to an LGBT center, or you go to a clinic and sample a group of people there who might not be representative of the population as a whole, but it's at least a first look at the group. There's another caveat on looking at the research on transgender people, which is that it's important to remember that gender identity disorder is still considered a mental illness, which anybody who's transgender could be diagnosed with. So when we're talking about mental illness, this is a group that automatically is already labeled with a mental illness. And also that transgender people, as a part of their transition, if they are going to make a physical transition from one sex to the other, they have to have contact with mental health in order to go through that. They have to have reviews, and they have to have the okay by the mental health community. But with all of those caveats, here's what we do know. In a sample of 515 transgender people in San Francisco, they found very high rates of depression. And in a New York City sample, there was also a very high rate of depression, highest in adolescence, which is a time when people are experiencing puberty, and if they're experiencing that in a body that they're unhappy with, can understandably lead to depression. And then there are also high rates of suicide attempts and very high rates of victimization. Studies on mental health in LGBT people have generally not included the more serious diagnoses such as bipolar disorder and schizophrenia, or they haven't found enough subjects in their samples to draw any conclusions. So we don't really know if LGBT people have higher rates, lower rates, the same rates of these diagnoses, but we generally assume that the rates are probably the same. And we know that as many as 2/3 of people with serious mental illness have co-occurring substance abuse disorders. And we also know from the studies that I reviewed that LGBT people have an increased risk of substance problems, so we kind of guess or infer that the incidence of co-occurring disorder in LGBT people with serious mental illness might be even higher than 2/3. So some special issues for this population. If we want to talk in general about people in the public mental health system, people with serious mental illness, there's very little written or studied about the sexual lives of people with serious mental illness. This probably goes back to a paternalistic view of people with serious mental illness, viewing them as people that need to be taken care of. And also this might have to do with the fact that these illnesses happen right when the person is in young adulthood, adolescence, right about the time that they would be dating, exploring their sexuality, and figuring out their identity. All of this may have been derailed by their illness. If we go back to Larry, Larry had his first hospitalization for mania when he was 17. He missed his high school prom. As his friends either went on to college or jobs, Larry continued to have relapses of his bipolar illness and repeated hospitalizations. He eventually lost touch with his high school peers. And as far as transgender people, having a diagnosed mental illness, especially a severe one such as bipolar disorder, may limit the ability of that person to undergo medical transition. So these are all reasons why discussing sexuality in LGBT people with serious mental illness is complicated. And it's also important to keep this in mind that we often don't inquire about people's sexuality at all. We have to be especially careful of that with somebody who may be LGBT and not assume that the person is heterosexual and not assume that they're asexual simply because they're not talking about partners or dating or interest in other people. Talking about sexuality is just like talking about sexuality with any patient is just another component of becoming more person-centered and recovery-focused. It's an important role and an aspect of somebody's life and something that we want to ask about. At the same time, let me go back. So keeping in mind this history of not really talking about people with serious mental illness and their sexuality or their sexual interests, it's really important, especially in this population, not to assume that the person is heterosexual and not to assume that they're asexual simply because they're not talking about their sexual lives or their love interests or dating life. Talking about sexuality in general with people with serious mental illness is just one more aspect of becoming person-centered and recovery-focused. And it also can have an important role in finding out about their illness and what they need in treatment. So to go back to Martha, the first person we talked about, Martha's primary care physician tried unsuccessfully for a while to treat Martha's depression using an SRI antidepressant and regular visits with the social worker in his office before he referred her to the mental health clinic. The primary care physician and social worker never asked Martha explicitly about relationships with women, and because she wasn't asked, Martha never revealed the precipitant of her depression. So here's an issue where we didn't ask about the person's sexuality, and it could have a major impact on their treatment and make the treatment unsuccessful. It's also really important not to confuse the person's sexuality with their illness, and the most common way this happens is perhaps is a lesbian who has post-traumatic stress disorder, trauma history, and in Abby's case, this happened with one of her counselors who remarked, maybe she would have been able to have a normal life with a man if she hadn't had such bad experiences with men in her childhood. While we know that there's not really good research on whether lesbians have higher rates of trauma, sexual abuse than any woman, there are some anecdotal reports that might be the case. We don't know that that's the case, but even if it were, it's a possibility that a girl or young woman who is identified as gender atypical or even as a lesbian may be at higher risk for being abused. And so it may be the other way around, that being different or being identified as a lesbian may put someone at risk for sexual abuse. But it's important not to confuse it in the other direction. So I talked about issues that are particular to this population. There are many issues that are not different at all, and that we need to remember the basics about treating people with serious mental illness. So we talked about higher rates of substance abuse in LGBT people, and that people with serious mental illness also have high rates of substance abuse. So we want to look for co-occurring disorders and treat them in the most up-to-date and appropriate way, which means integrated treatment, treating the substance problem and the mental health problem in the same place, if at all possible, using techniques like stage-based treatment, tailoring the type of intervention to what stage of recovery the person is in, and motivational interviewing. And so this happened with Roger. His day program has counselors trained in both mental health and substance abuse treatment. They're beginning to engage him using motivational interviewing, working with his family who attend regular treatment, and by offering him small tokens for attendance at a Should I Get Sober group. We also want to remember the research on people with serious mental illness and the dramatic 25-year reduced life expectancy due to chronic health factors like smoking, weight, diabetes. And so, you know, again, going back to the basics, we want to just for our LGBT patients with serious mental illness, as for anyone with serious mental illness, talk about smoking, talk about physical activity, follow the person's weight, and make sure that the person has a primary care doctor. There is a growing and actually pretty large body of literature now on lesbian and gay affirmative mental health treatment. This literature talks about LGBT identities as normative in contrast to the previous literature from psychoanalysis, which did not do that, and also talks about the therapist and the patient examining their anti-gay feelings that they may have been brought up with or gotten from society or parents as an important part of being gay affirmative. It's also a big component of this literature and how to be gay affirmative is knowledge about some specific issues like coming out as a central developmental issue of all LGBT people. And it's an issue that's ongoing throughout the person's life. So Larry encountered this in his treatment, and in frustration one day, Larry's therapist asked him, "Why can't you just accept that you're gay?" Larry misses the next several appointments. The therapist found, and after that, and attended a professional conference in a nearby city on treating LGBT people and learned more about the coming out process. The one drawback of this literature, and it's at this point very good and very extensive and very clinically oriented, but it's not focused on our population. It's generally not focused on serious mental illness. It's focused on the more high-functioning, worried well population. Yet there's a lot in there that's very applicable to people with serious mental illness. Because this literature is not really focused on people with SMI, it's not as well known by clinicians and psychiatrists that work in the public mental health system. And a couple of small studies showed that many LGBT people report discrimination, insensitive care in the public mental health system, and that they're not satisfied with their treatment. On the other hand, many communities that have LGBT centers, community centers, may not really be welcoming to people with serious mental illness. They may have support groups, but they're not really focused on that group of patients. And similarly, AA and NA chapters may have special groups for LGBT people, but they're often not groups that may be more appropriate for people with serious mental illness, such as double trouble recovery groups, where it's okay to be on psychiatric medications. There are a few groups and specialized services that exist for LGBT people with a serious mental illness that bring both of these groups together. There are some peer-run psychosocial clubs, and there's one at South Beach, for example. There's one in Queens. There are services within larger mental health programs that are specific for LGBT people. And there are services within specialized health centers, such as Fenway in Boston, Callan Lord in New York, within that for LGBT people with mental health needs. But there are many places and places throughout New York State, especially outside of New York City, where there are no services for people with LGBT people with serious mental illness. So what do you do if you're a clinician and there's nothing in your area? And often when we read case reports about somebody treating a gay patient, the first thing that's recommended is that you go find an expert. Well, what if there is no expert in your area? So a few things that you could do. You can ask about services at the local mental health center. If you're not the one working at the mental health center, you can call up the local LGBT community center if there is one and ask about services for people with mental illness or people with serious mental illness. You can, if there's a place that you know of that is not close to you, you can call them up and ask for consultation. Often these places have a website. You can get information off the website, and you can encourage your patient to get information off the website. You can go to conferences such as the American Psychiatric Association, American Psychological Association. Different mental health conferences will have sessions on treating LGBT patients. Go to those sessions and get training. And you can advocate for the creation of services where none exist. And often, if you are in a place trying to treat the patient the best you can and there is no expert, you have to become the expert, or you have to become the advocate. So this is the reference to an article that this talk came from, if you want to read further and with a little bit more detail about what I've been speaking about. So in summary, I would just like to say that this is a population that we frequently encounter in our services, and there are many things that we can do for LGBT patients that are the same as we would do for any person under our care. And there are many things that we need to know about that are specific to those patients. And by knowing about those things, we can be more effective with our patients. Thank you.
Is there any, do you want to reference any email addresses or anything like that before we stop? I'm still running.
And then stop that. Hit that. Stop it.
Okay. Well, there was also a... Well, I don't... And in the spirit of giving you some other places to go to get more information on this topic so that you can become more of an expert, there's an online curriculum that I helped develop with the Group for Advancement of Psychiatry, the GAP, and that is freely available. It has different modules. You can go through each module in about 15-20 minutes, and there's a pre- and post-test. You can test yourself. And this is available at aglp.org/gap.
Thank you very much.
Thank you very much, and I hope you've enjoyed this talk.
Okay. We have a presentation.
We're going to do that. We're taking breaks. Yeah.
So how does this compare to a live presentation? Do you feel more comfortable being able to go back over the bad parts, or would you just like to wing it?
I would rather wing it. Yeah, because then you think about every little stumble, you know, whereas if you're doing it live and you can't go back, it's like whatever.
All right, well, I should have something to show you fairly soon. What I'd like to get, if you can email me that slide set, and what I'll do probably sometime over the weekend is I'll start putting some slides in, but I'll give you a sample snippet of the opening shots probably by Tuesday. Hopefully by, well, we're going to shoot on Thursday and Friday of next week, aren't we, Hector?
Yeah.
Okay. So let's figure in a week or so we'll have something, depending on what else is piled up on my desk.
Do you have a copy of your notes? I'm preparing for something. So anything like a PowerPoint, maybe I'll merge and reference some of the stuff that you said as well. I can get a copy of them. This was really great.
Has it.
Okay, great. Because then what we can do is I'm going to use snippets and refer back to what we just did and cite the work that we talked about. And
There's a couple questions I'm going to ask her.
Yeah, I edited this journal, and so that this article went into the journal.
Did we get disconnected, John? I don't think so, did we?
Did you want to post?
Yeah, yeah,
You do? Oh,
yeah. I mean, I don't think we got disconnected here, right? I think we're still in webinar, right?
I don't know.
advisory
I'm not-
committee.
We're still in webinar, we got disconnected.
What happens
I
is,
just
what
put
we've
on
actually
pause, we're
talked
still in.
about, I'm trying to
So
create
the
and
question-
replicate that in the different
It's not
counties
stopped.
because
We have to get the set dressed a little bit better now. So get into the position similar to the last previous.
Stop moving away from me, Hector.
All right. Both of you have to come this way a little bit.
Yes.
there's a
got-
cultural experience about first right?
Not too much.
Could you both talk a little bit so I can sound levels good?
Okay.
Dr. Pavone? Hello,
Hi.
hello?
Hello. Oh, it's clouding up. Look at that.
1, 2, 3.
Yeah, let me drop this one down. Okay, keep talking.
Okay.
Hello? It's a
Hello,
great-
we're still here, and we finished the talk.
Looks like it's going to rain.
Yes, it does.
All right.
But at least it's not going to snow.
Hey. Travel back would be a lot easier.
I just have to do a couple of things here.
Oh, these things.
That's fine. I'm going to pull this one. The little mic can stay right where it is because it looks like I'm doing nothing.
You did a great job.
Thank you.
Okay.
Very informative.
So how do you want to open up into this? Do you want to say?
Well, I'm going to say thank you. I'm going to say thank you for the presentation, and I'd like to have some questions,
All right. And then just do it as naturally as you want.
I'd like to have some questions. We have some questions. Because there's nobody that'd like to have the questions from, right?
I ask them all the time. That's what I try to tell you. I mean, I have another question for you.
Okay, we can start whenever you like.
I'd like to thank Dr. Mary Barber for the presentation. It was very informative, by the way. But I have some questions for you. Hopefully that these questions will help our viewers, again, in regards to how can we better engage the LGBT population. So my question to you is that you brought up a great discussion about sexual orientation and the importance of understanding what that means from the patient point of view. What guidelines could you give or recommendations could you give to help clinicians or providers to ask those questions? Do you have any recommendations along the lines?
Sure, Hector. Well, the first thing I would say is just don't be afraid to ask, because often a clinician may be afraid to ask questions about something they're not sure about or they feel a little bit uncomfortable about. So the first thing is to just not be afraid to ask the questions and to ask them in a neutral way with all patients. Are you involved with anybody? Are you dating anybody? Are you interested in men or women or both or neither? And to ask these questions in general, neutral terms. Sexual orientation, as I kind of alluded to in the presentation, is complicated. So somebody may be attracted to both men and women, but maybe only have relationships with men, that they may identify in a different way. Those are complicated layers of identity. And so you want to also know what you're asking about. So if you're asking a question that's about HIV risk, you really want to know about behavior. But if you're asking about love and dating and relationships, you want to ask about the person's attractions and how they identify. And the answers to those questions might be different. And they also might change over time as the person grows into their identity.
And another question I have, because from my experience being a clinical social worker for 10 years, is I think how our mental health model views sexual orientation or gender identity issues. As, for example, transgender is a disorder. How do you feel about dealing with that aspect in regards to that, how sometimes our model in regards to DSM-4 classifies people's sexual orientation as a disorder? I mean, how do we...
Well, sexual orientation has not been a mental disorder since 1973. So that was put to rest a long time ago because of a lot of research that went on, mostly by psychologists and sociologists. But it's true that gender identity disorder, as I talked about, is still a diagnosis in the DSM. That's a complicated thing because there are actually some people in the transgender community that want that diagnosis so that they can get insurance to hopefully pay for some of the interventions like hormones, like possibly surgery. So there's not total agreement about what's the best thing to happen with that diagnosis, but it is actually being looked at right now by the DSM committee for DSM-5, whether to take that out of the manual or keep it in. And I think with transgender people particularly, clinicians may not be comfortable because it seems so different to them, and maybe they're more used to now seeing lesbian and gay people in the media and more open people in their lives, but maybe less so with transgender people. So it's all the more important to kind of get knowledgeable about it and be open to hearing what the person has to say about themselves. How do you identify, and what is important to you, and what are the things that are meaningful for you, and help me understand what this or that term means. It's really okay to do that with a patient.
Because one thing I heard from you, I guess in Larry's vignette, when you discussed Larry's case about his bipolar sexual orientation, it's almost like to see like what is the real issue, you know, his acceptance of being gay or his bipolar. Like, it just seems like a dichotomy there where it's like there's a split. In those challenges, what do you recommend? Because it seems like there's still a struggle there with him.
And there could have been a struggle around both of those issues, right? His acceptance of having a bipolar diagnosis and having to come for treatment, and his acceptance of being gay and being in a relationship. So there may be issues around both of those. You have to be where the patient is. And so you saw when the therapist tried to say, oh, you're gay, just admit it. That's not going to be helpful for the patient. That's not where they are, and that's actually very frightening to a patient to try to prematurely push them in a certain direction. Issues around identity, they're going to have to decide for themselves. We can't decide that for them. I have a very good friend, a very experienced clinician in this area, who says to people, I don't care what you are. It doesn't matter to me, and I can't tell by looking at you. You're going to have to figure this out for yourself. He just explicitly throws it out that way. And you could think that that would be very scary for a patient, but it's actually more comforting for the patient that there's no test that we can do to tell what their sexuality is.
Right.
These are issues around identity that people have to resolve for themselves.
So, I mean, are you aware of, do you know of any type of, let's say, assessment tools in this area that could assist clinicians, or any type of educational information or web information that people can go to get more information about LGBT groups? Yeah,
there's a lot of information out there. So I mentioned that the GAP curriculum on the AGLP website, which AGLP is the Association of Gay and Lesbian Psychiatrists. It's an excellent organization. I was the president of it, and now I edit their journal. And there's a lot of information on their website as well. There are some bibliographies and some reference information, and also information on where you can go for meetings where we have talks about, a lot of talks about treatment of LGBT people.
I think one concern, from my experience, I had colleagues who were uncomfortable working with clients that have an LGBT background, if you want to say, that describe themselves as being LGBT. I think that involves about a little more self-exposure to ourselves. How can clinicians better adapt? I mean, what's your recommendation for helping clinicians overcome their barriers?
Sure. I mean, I think a lot of the barrier may just be lack of knowledge, so getting knowledgeable can be very helpful talking to a colleague just as you would about any feelings that you have about a patient, any uncomfortability, what we used to call countertransference, is always helpful, getting supervision around those issues. And what is making you uncomfortable, and is it something that means that you can't continue to effectively treat this patient, or is it something that you feel like you can be enough open to that you can discuss? I talked about in the literature on gay affirmative therapy that this is a major thing, that even the most open, even a gay therapist may have feelings come up during the treatment that harken back to their biases that they learned growing up, or biases from their parents, or something that they different biases that they have, that society has. Those are bound to come up in both the patient and the therapist. So it's not something that you have to feel like if that comes up, it means the therapy's no good, the treatment's no good. You just have to be prepared to be open about it and deal with it. Like for example, the person who is in a gay relationship, and the relationship breaks up, and the patient comes in saying, "Oh, I knew it. This would happen. Gay relationships can't last." It's repeating something that's a bias that's out there. So does the therapist buy into that, or do they challenge that? And so that it's not that those things won't come up, but they just need to be looked at.
I really do appreciate you being here today and taking the time to address an important area that the Bureau of Cultural Competence recognizes, and we look forward to hearing from you again in the future on this topic, and I thank you for coming today.
Sure, thank you.
Thank you. This again concludes our webinar presentation. This is Hector Rabone from the Bureau of Cultural Competence, and we'll be seeing you soon.
You guys are ready for prime time.
You are getting good at this, I think. It's great.
Very, very good.
Good questions.
Oh, thank you.
Your voice is a little scratchy, but what's up?
Need water. Look, a sippy straw. Those are big question.
I know.
The straw comes in from the back.
W.
And then you pull away. We can edit that.
We're not rolling right now. So you can say that.
Fantastic.
Okay. How much time do I have to tear this place down? To